Morning all of you. My topic is glomus tumor atypical presentation. As glomus tumor is a benign mesenchymal neoplasm, it comprises of less than 2% of soft tissue tumor and it arises from the glomus body, which is a specialized structure within the dermis that is involved in the thermoregulation. These are the rare tumors and can develop in any part of the body. They are most frequently occur in the hand, account for the approximately 75% of the cases. Epidemiology, most common age group is 20 to 40 years. It is equally common in both genders, but in subungual lesion they have female preponderance of ratio 3:1. It described throughout the body. Most common location is upper extremity, accounts for 62% of cases, particularly finger is 27%. Subungual region is the most common location on the fingers. Other sites are trunk wall, internal organs like stomach, liver, pancreas, GI and genitourinary tract. And 9% of the cases is reported in lower extremity and head and neck is 7%. Malignant glomus tumor are exceedingly rare, comprising as high as 2.9% of all the glomus tumors. The classical symptoms of the glomus tumors are pain, tenderness and cold sensitivity, and on physical examination finding that there is point tenderness on the site of the lesion, and there is a sign called Hildreth sign. There is reduction in the pain when we inflate the cuff above the systolic blood pressure proximal to the tumor. Although a history of prior trauma is sometimes reported in association, these tumors are there in these tumors and there is no definite causative relationship has been established. Patient typically present with subcutaneous nodule that may vary from red to purple depending on the depth of the lesion. They are typically benign, solitary lesion and small and rarely exceeding 1 cm in greatest dimension. It usually forms bulging unencapsulated mass with an irregular nodular dark red surface. When multiple, the tumors are usually 0.1 to 0.3 cm in diameter, but lesions up to 3 cm have been reported. On histological examination, it is typically composed of three components: glomus cells, smooth muscles and vessels. Classical histological feature of the glomus tumor include there is angiocentric uniform sheets of cells with oval nuclei forming a perivascular collar around the vessel. Glomus tumors are characteristically and diffusely immunoreactive to smooth muscle actin. This is a case. A 46-year-old male presented to our plastic surgery OPD with a 2-year history of swelling over the dorsal aspect of head of the fifth metacarpal on right hand. The swelling was intermittently associated with sharp episodes of pain which exacerbated on touching the cold surfaces, but there is no history of any preceding trauma. On examination, there was 2 to 2 cm oval-shaped swelling was observed on dorsal aspect of head of fifth metacarpal. The swelling is soft in consistency, tender on palpation, non-pulsatile, non-adherent to underlying structure, normal overlying skin. Patient underwent surgical excision under local anesthesia followed by histopathological examination. This is the pre-op picture which is showing the lesion on the head of the fifth metacarpal. This is a 1-month-old picture after excision of the lesion. Differential diagnosis to be in lipoma, angioma, neuroma and leiomyoma. These are the cells which coated in the black. These are the blood vessels, and around which dotted in the blue lines. These are the tumor cells which form the perivascular collar around the blood vessel. And the yellow percent there is a hyalinized stroma. Histopathological examination confirms the diagnosis of glomus tumor. The glomus tumors are typically extremely painful and often present early. Clinically, the solitary lesions are characterized by the reddish-purple discoloration of the lesion, paroxysmal pain, tenderness, sensitivity to cold. Although glomus tumors are thought to arise from glomus cells, these have been observed in extracutaneous locations that are not known to contain glomus cells. Occasional glomus tumor may exhibit unusual clinical features, that is large size, deep soft tissue, visceral location, infiltrative growth pattern or multicentricity. The routine laboratory studies are not useful for diagnosis of glomus tumor. High resolution MRI provides more precise assessment of the tumor characteristics when located in deeper tissues. Glomus tumors are most common neoplasms that can occur in various tissues throughout the body. Despite their relative common occurrence, these tumors elude the diagnosis, leading the patient to seeking consultation with multiple specialists. Undergoing series of diagnostic tests before an accurate diagnosis is established. Early recognition of the glomus tumor is critical, and a high index of suspicion is essential to reduce both patient morbidity and potential for malignant transformation. Timely diagnosis and appropriate management are key to mitigating the complication and improve the patient outcome. These are the references which is used for this study.
Any questions from the audience? So in this case, what was your initial diagnosis on examining the patient?
On initial diagnosis, it was a lipoma. But on histopathological examination, it was confirmed that it was a glomus tumor.
Any investigation which you did between the surgery and the clinical examination? Any imaging, anything? You mentioned that?
Sir, I cannot do any investigation for
this. So you strongly felt that it is a lipoma?
Yes, sir.
But then you said the history of pain on cold and touching was already there.
Sir, it was there, but patient.
It's difficult to explain about lipoma given these kind of clinical signs and symptoms.
Sir, I have not done any routine investigation for this lesion. I suspect on lipoma or neuroma or any leiomyoma.
Very good. If you suspected this thing, then why did you not go for MRI or something? If you suspected, you suspected neuroma or angioma or something. If it was pure lipoma, then okay, we also exercise sometimes like that. But if you suspected something, then why you do not do any? Yes.
So we can go for that, but I can.
What test you will do for this thing? What test you will do?
Sir, histopathology is the confirm for the diagnosis.
What's the institution of choice for such patients?
Investigation, there is no investigation.
No, I'm telling you, if you have a case in future, what is the best?
Sir, MRI is the.
Right away going for MRI before any other investigation?
Sir, we can go for an ultrasound also. So, it can show the hypoechoic lesion.
So ultrasound is a simpler investigation than going for MRI directly. And if they give you a suspicion, then only you go for either FNAC or MRI of the region also. Yeah, Dr.
You described the love sign, that there is a pain, a pinpoint on touching. So, did this patient have that pain or not?
Sir, there is tenderness present on the site of the lesion, but patient have an on and off pain. Patient has previous.
Do you have that kind of a pain in lipomas?
No.
So I think the clinical diagnosis would have been made much more easily than saying it lipoma, and then accordingly you should have done the investigation. Anyway, thank you so much.
Thank you.
Next we call upon Dr. Sumit Jain. He's not there. He's already there.
Good morning, respected teachers. My topic for presentation is the synergistic integration of dermal matrices and negative pressure wound therapy in post-traumatic wound management, our institutional experience. So, the post-traumatic wounds often present complex challenges due to factors such as tissue loss, infection risk, and prolonged healing times. Dermal matrices are designed to provide a scaffold for tissue regeneration, while negative pressure wound therapy promotes healing. Despite the established benefits of dermal matrices in chronic and post-burn wound healing, there is a lack of comprehensive studies exploring the effectiveness of dermal matrices in post-traumatic wound healing. Now, we know that dermal matrices are included in the reconstructive ladder, and in this study, we have used Integra, Matridum, and biodegradable temporizing matrix. Integra is a bilayer which the outer layer has a silicon and inner layer contains collagen and chondroitin 6 sulfate. Mainly, it needs 2 stages, but it is also single stage can also be done, but it doesn't provide the stable wound, stable cover. Metriderm comes in 3 thicknesses, and it is more close to human dermis. And the biodegradable temporizing matrix, it is a synthetic layer, and it also needs 2 stages. This study aims to evaluate the efficacy of dermal matrices combined with negative pressure wound therapy in the management of post-traumatic wounds. This is a retrospective observational study done at Amandeep Hospital, Amritsar. For the duration of 3 years, we included 70 patients, in which 25 patients had Integra application. We applied Metriderm in 30 patients, and BTM was applied in 15 cases. Follow-up at 6 months interval was done. All patients with post-traumatic wounds in which dermal matrices were applied were included, and loss to follow-up of patients were excluded. We applied dermal matrix in conjunction with NPWT, and Integra and BTM were applied for 3 weeks, and the Metriderm was checked for 10 days. We measured scar quality using Vancouver scar scale and assessed the complication like failed integration and partial graft loss. Our indications for using the dermal matrices were small area with bare bone or bare tendon, lacking periosteum or paratinon, surrounded by a vascularized wound bed. Areas where good aesthetic outcomes are needed and FTSG cannot be done. And when paratinon and periosteum is intact, addition of dermal matrix can give more durable cover. We didn't use in the active infections when secondary surgery is anticipated and when more than 2 to 2.5 centimeter of bare bone or tendon is present. It gives full thickness cover, pliability of skin, stable skin cover compared to SSG alone. Here are the few cases I am showing. Metriderm, this is a 25-year female, college-going female. It is a post-traumatic scalp avulsion. So the replantation was attempted on day 1. On day 6, there was replant failure. We removed the replant and applied VAC. After removing VAC on day 11, 1 mm Metriderm was applied, and in the same stage, SSG was applied. So VAC applied on the day 22. First SSG dressing was done, and you can see at 6 months follow-up, she has a good color match and good scar quality. She didn't want any scar, so the flap option was given, but she didn't need any scar, so we gave her option of dermal matrix. Next case, 45-year female with left arm, forearm and hand crush injury. Multiple debridement of wound was done, VAC was applied. As we initially planned for the flap, but we found thrombosed vessel, so we applied the dermal matrix, VAC and SSG was done. We can see the follow-up at 1 year. 40-year male with degloving injury right foot, Metriderm was applied. We can see the scar quality. Integra, this is a 9-year male with post dog bite wound scalp. Here we debrided the wound and drilled holes into the bone and applied Integra. VAC was applied, and this is the follow-up of the skin scar quality. This is 25-year male, crushed near total amputation toe. Here the Integra was applied because we were not able to salvage the toe. We applied the Integra. Multiple dressings done, SSG applied, and this is a 6 months post-surgery. Good skin quality, no wound breakdown, no unstable scar. This is also a finger case where at 1 year follow-up the scar quality was good. BTM, this was an extensive injury of bilateral lower limb where full thickness skin was involved, debridement was done, graft was applied, and this is the 6 months follow-up of the patient. 52-year male degloving injury left thumb. Here the graft was applied and the scar quality. And the 8-year male with right foot degloving injury, where you can see the tendons are exposed, and we applied BTM, and still we need follow-ups. Here the young female, she has extensive wound on his abdomen and thigh. We applied the BTM, and so the aesthetic appearance is good, and we need more follow-ups. These are the results, patient demographics, and complications in various groups. This in 6-year male we can see post-electric burn left wound. After debridement, we applied Integra, and there was loss of Integra due to infection, so it was salvaged by the flap. This is the comparative group at 6 months after surgery. Many patients are still under follow-up, and we compared. We assessed the scar index score at 6 months follow-up and at 1 year follow-up. In 1 year follow-up, only Integra and Metriderm group were included. This is the scar index. The results, total participants were 70, mean age was 42 years. Scar quality was nearly same in all three dermal matrices, but statistical differences between groups could not be compared due to insufficient follow-up. Complications were 11.5%, manageable through standard clinical intervention. Then in our study, we have observed significant improvement in healing rates and complete wound healing in 88.5%. Integra was more prone to loss due to infection, and BTM can resist infection to some extent. Upon observation, short-term follow-ups of BTM showed good aesthetic appearance. However, we have recently started using BTM, and as there have been fewer cases thus far, longer follow-ups are needed to assess BTM efficacy. Limitations were cost factor, availability, observational nature of the study limits causative conclusions, potential biases in patient selection and treatment protocols, small sample size and longer follow-ups are needed. Conclusion: the combination of dermal matrices and NPWT in wound management present a promising strategy for treating complex wounds. When small areas of bare bone or tendon is exposed, flap is an overkill, and future studies should aim to evaluate larger population samples and conduct long-term follow-ups to further validate and refine these preliminary results. Thank you. These are the things.
Thank you for finishing on time. So, what is your recommendation after doing this study?
Actually, first we used Integra. Initially, we started using Integra. That was 2-stage, and it was more prone to infection. So, Matridum came in the market, and the advantage of Matridum was that it was available in 1 mm, so that we can do the surgery in the single stage. And the BTM, then BTM came up. So it was also it also needed 2 stages, but what we are seeing initially is that short-term follow-ups, scar quality is good in these patients, and it is more resistant to infection. So we are trying.
ADM is integrated. In which wounds is ADM integrated? In which wounds would you like to use these materials? All cases of deglobin?
No, sir.
Yeah.
In case I showed, there was bilateral lower limb injury in which we cannot do flaps, and there is extensive injury, so the vessels are thrombosed. So flaps.
Is a replacement for flaps?
Not exactly, because there are certain indications to use dermal matrices.
Put it simply, how do you choose a patient for these dermal matrices?
First, if the flap, where the flaps cannot be done, or the flaps will be bulky, like in dorsum of hand, or in the areas where we need aesthetic, good-looking appearance in those areas.
Which would be those areas?
Like hand, finger, digits, and abdomen. I showed in the female and male also.
Any questions other than this? Even judges can ask questions. Yeah.
You showed a case of exposed calarium with burr holes.
Yes.
So what did you use in that case?
I used Integra.
And used skin graft in the same sitting?
No. Integra is for 2-stage. It is a 2-stage procedure because we have to remove the silicone layer and then we have to graft.
What happened to the bone between the drill holes?
Sir, there was blood supply was granulation actually occurred after doing the drill holes after 21 days when we removed the back. So it was a good wound bed for grafting.
Same thing about the tibia also?
Yes.
Same thing in the tibia, lower limb?
Yes, sir.
So, as per your indication or inclusion criteria, how much width you had chosen for coverage?
Sir, if bare tendon or bare bone is exposed, then we are using a width of 2 to 2.5 centimeter for for use of
That's
dermal
my
matrix.
question, that you have used word 2 centimeter,
Yes.
right? So 2 centimeter of bone you are using for Matridum or acellular dermis matrix coverage, right?
Yes.
So you are using drill holes in those bones or without drill holes?
Sir, we are in some cases we are using drill holes where we see there is no periosteum.
No, We are banking on the bridging phenomenon. No? What
Yes,
is
sir.
the dimension of the bridge which you can safely cover with?
2 centimeter.
2 centimeter.
Yes, sir.
Okay. Thank you. Thank you.
Thank you.
I would like to call the next speaker, Dr. Vandana.
Shall I start, sir? Good morning, everyone. Today I will talk about my study on outcome assessment of autologous ear reconstruction in unilateral microtia using CAD/CAM and 3D printing. As you all know, ear is a complex 3D structure whose carving is challenging on a costal cartilage. It really requires good artistic skills, and a 2D template which we use, which is a conventional method, fails to deliver the accurate information about the 3D geometry of the ear. These constraints can be overcome by the use of a 3D template produced by CAD/CAM technology. It serves as a usual guide intraoperatively. The aim of this study was to assess the outcome of ear reconstruction, and the objective we used 3 criteria: weighted grading system, Mansour ear reconstruction scale, and GCVI questionnaire. According to weighted grading system, it is an objective system where 1 point is given to all the anatomical landmarks in the newly reconstructed ear and total score is calculated. According to Mansour ear reconstruction scale, 3 scales were used, and photographic scale, patient satisfaction scale, complication scale, and total score was calculated. According to GCVI questionnaire is a set of 24 questions where points are given according to Likert scale and total score is calculated according to it. Coming to methodology, it was a prospective case series done from July 22 to December 23 in a tertiary care hospital with sample size of 9 patients. Patient underwent ear reconstruction in 3 stages: framework fabrication and placement, 6 months after that framework elevation, 3 months after that global transposition. Coming to inclusion criteria, patients more than 8 years were included with unilateral microtia of all grades, patients with bilateral microtia, acquired ear deformity, and patients with unilateral microtia with severe facial deformity were excluded. Coming to the methodology, first NCT phase with 3D recon was done and a DICOM file was obtained. Coming to it, then next step was the DICOM file was converted into STL file format. Then the image was inverted to produce the image of ear being reconstructed, and further editing was done by SolidWorks software. Then the 3D slicing software was used, Prusa slicer, to slice the STL image into layers. And then the 3D model was printed using Prusa printer, and the material used a polylactic and glycolized polyester. Gas plasma sterilization of 3D printed model was done for its intraoperative use. As we can all see, this is the NCT image of a 3D recon image of a patient, out of which a normal ear was edited, and it was converted into the STL image, and the STL image was inverted to produce the image of the ear being reconstructed. Coming to the preoperative marking, we marked the root of helix from measuring the distance from nasine and menton, and we replicated on the opposite side. Then we marked the axis of the normal ear and the dorsum of the nose. We draw the 2 parallel lines and we measure the angle between them. And then the same angle was used to mark the axis of the newly reconstructed ear on the opposite side. Then the costal cartilage was harvested and the framework was fabricated out of it. We used wires to measure the length of helix and anti-helix intraoperatively and compared with the 3D template. This is the immediate post-operative result following stage 1 fabrication. This is an image of the patient who has undergone all 3 stages of microtia reconstruction using CAD/CAM technology. This is an image of another patient who has undergone microtia reconstruction using CAD/CAM technology. Coming to observations, 2 patients had cartilage infection, 2 had cartilage exposure, and 5 had no other complications. Coming to weighted grading system, all 9 patients had excellent outcome. Coming to Mansour ear reconstruction, 7 patients had very good outcome and 2 had excellent outcome. According to GCVI questionnaire, our mean score was 75 and highest score was 83. As we compare, according to Mansour ear reconstruction with his original study, our study 78 had very good outcome and 22 had excellent outcome, whereas in their study 60% had excellent outcome, 30% had very good outcome, and 10% had fair outcome. We also compared our study with another study who had also used GCVI questionnaire following microtia reconstruction. Their study reported 65 average score, and our study reported 75.5 as average GCVI score. Coming to conclusion, our study used both objective and subjective criteria to demonstrate better results of microtia reconstruction using CAD/CAM and 3D printing, excellent outcome of microtia reconstruction, was seen using weighted grading scale, and very good to excellent outcome was seen using Mansura ear reconstruction scale. Patient also reported improvement in one general well-being, daily to daily activities, and boosting self-esteem using GCPI questionnaire. The limitations of this study that it requires validation by more number of studies and larger number of patients with multi-center studies. The future prospect of this study can be that it can be used to create bilateral symmetrical 3D template in cases of bilateral microtia. The 3D template can also be used for simulation training for carving of cartilage framework by the residents, and it also forms a roadmap for 3D data for 3D bioprinting. Thank you.
Any questions from the audience, judges?
So what was the benefit of printing the ear before going to the OT? Could you clarify? Because I think you were presenting in a bit of hurry, so we couldn't catch it. Since there was some time. So what was the benefit for the audience? You can tell.
Sir, the benefit is in the 2D templates, we have difficulty in judging the depth of concave ball. That ear has to be reconstructed in 3 different layers of concave and helix and anti-helix. So when we use a 3D template, we can better judge the relative symmetry, relative anatomy of helix, anti-helix, and concave ball.
To put it simply, how do you transfer your 3D printed ear to the cartilage framework? What is the process you transfer? By observation or by some measurements?
So first of all, we exclude the size of the lobule, which is included in the 3D template. Then we measure this. Then the rest of the height was calculated, and we also measured the using wire length. We measured the length of helix and anti-helix.
Did you use wire to transfer the?
Yes, sir.
It is different if you do
How it is? Yeah.
CAD-CAM. With and without CAD-CAM, what is the difference? Then only we will know that it is useful.
Which dimension it helps?
Sir, using CAD-CAM, basically we are replicating the exact dimensions of the normal ear, which cannot be done. Well, you use 2D template, and whenever you are using a 2D template, we are not able to make the different layers of the ear. Basically, ear has to be reconstructed in different layer of concha, helix, and anti-helix.
This is hypothetical. Unless you do clinical and 3D CAD-CAM, then only you can show the difference between two.
That is true, sir. But in our study, we had used objective criteria to show that all the anatomical landmarks were present or not, and we also used in another criteria patient satisfaction scale, complication scale, and photographic scale were used. So that's how we evaluated our results.
The model that you made and the cartilage construct that you made, how do you judge both are same?
In other way,
Sir, we had compared the length. We had compared the length intraoperatively of helix and anti-helix.
Length is a single dimension. Na? How do you compare these? Did you take some measurements and you transferred those measurements onto your reconstruct? Otherwise, just you monitored them visually only.
So we have compared the height. First of all, we excluded the lobules.
Measure them and transfer them to your construct.
Yes, sir. We have measured the height as well as width of the ear.
These are two dimensions.
And basically the height, basically the concal depth anatomy we were better able to judge in with a 3D template.
Just listen. What he wants to know is that you constructed the model, and now you have carved out from the cartilage. What is the comparison about the depth and all? How did you measure? Did you measure after your carving? How did you compare it to the model?
We have assessed it visually, sir.
Visually. So that is what
your 3D reconstruct, it includes soft tissue?
It includes skin.
Or it's just a cartilage?
Sir, it is an NCT while obtaining the NCT file DICOM image, only the cartilage is taken, sir.
Only cartilage, but you have shown complete ear.
Complete ear, but the skin thickness is only 2 mm or minimal, sir. In a normal ear.
What percentage of the data is excluded while making the DICOM image and then the steel file? One. Second, how do you transfer the depth? As you are repeatedly saying, that routine template will give you 2D image, you got a 3D image. So how do you transfer the depth part of the 3D model to your construct? And what percentage of the data you reduce from the STL file while reconstructing from the DICOM file?
From the DICOM file, we have exactly copied the 3D template. Considering the skin thickness is very minimal of almost 2 mm in ear. And sir, regarding conchal depth, we have measured it. We have not measured it specifically, but we have just observed. We have just compared.
You are passing reference to some wire which you used.
Wire measurement was done of helix and anti-helix, sir.
Agreed. Thank you.
Skin thickness is even more than the cartilage thickness.
Sorry, sir?
The cartilage thickness is lesser than the skin thickness on both sides. So you are saying it is very minimal, but the cartilage is even thinner than it. So perfection नहीं है ना, perfection नहीं आएगा ना, क्योंकि 2-3 मिलीमीटर का ही तो मामला है.
Anatomical landmarks आ जाएंगे.
उसका cartilage मोटा है. So better way is we should make negative and then we reconstruct over it. We make negative 3D printer, negative image rather than making a positive image. So you make a negative model like we make the cast, and then you take the cartilage into it. That will give you the exact how much you want.
Negative image will also have some errors.
Yes.
It will be more prone to errors, sir, than our CAD/CAM technology.
No, CAD/CAM. By CAD/CAM you make negative model.
Agreed. So maybe thank you. Thanks for generating such a nice discussion. And may I call the next speaker, Dr. Ashok, for his presentation.
A very good morning to everybody present here. This is Dr. Ashok, here to present my paper on dermal implants, a road opposite to conventional treatment for wound management. So, introduction about dermal implants. It's a dermal substitute made of collagen and elastin. Being derived from animal sources like porcine and bovine, these undergo a process of decellularization so that it elicits very minimal immune response. It abides by the principle of biomimicry, where it forms a scaffold, a bridge-like thing on which the cellular regeneration takes place by migration of cells, blood vessels, and soft tissues. Now, this has renovated plastic surgery in 3 main domains. One in burns, where we suffer the deep burns, and these dermal implants can go at a deeper layer, regenerates, and the elastic component in the dermal implants can make the elasticity more soft, thereby reducing the burn and fracture. In diabetes wounds, the collagen part of dermal implants, as well as a bit of moisture, strengthens the type 1 collagen and helps in tissue repair for better healing, stronger wounds. In aesthetical, for scar excision and soft tissue defects, these dermal magnets can give a proper contour lining, which we weren't able to achieve earlier. The advanced versions can include growth factor, platelet-derived growth factor, epidermal growth factor, and few antimicrobial impregnated can limit infection. Now, this seamlessly integrates with the host tissues. This obviates the need for donor site mobility in case we are avoiding flaps. Now, thanks to this groundbreaking regenerative medicine, in where we are able to achieve form and function. In my study, the aim is to measure the percentage of graft uptake at week 4 and week 12, post-skin grafting in cases where dermal implants were used. Secondary outcomes were matrix integration, wound infection rates, serum or hematoma formation, patient satisfaction, functionality, and cosmesis. It's a prospective study at our institutions involving 25 patients for a 1-year period from December 23 to November 24. After obtaining consent, detailed history examination, sending routine investigations, wound swab cultures. Now, radical yet meticulous wound debridement was done. As a first stage, matrix was placed over the defect, filling the soft tissue gap, providing a scaffold. And wound assessments were done based on the millimeter thickness. If it is 1 millimeter on day 5, 2 on day 7, and 3 on day 10. Now we were monitoring signs of infection and integration. Now once it is fully integrated, as a second stage, we put the split thick skin graft, and it was secured with staples or skin sutures, and negative pressure wound therapy was applied. And first graft look was on day 4, subsequently 6 and day 8. The follow-ups were on 15th day, 1 month and 3 months. The key outcomes were analyzed for graft uptake rates, complication rates, functionality and scar quality. In results, foremost the demographics, a slight male preponderance was there of 56%, and age-wise demographics, the geriatric population over 60 to 70 years, they had the leading percentage, closely followed up by the pediatric population of age 0 to 10. Etiology, a whopping 60% was due to trauma, either because of road traffic accidents or mechanical injury. The other risk category were chronic wound as well as burn wound. Diabetes led in the comorbidities category, followed by hypertension. And location of wound. Half the patients had the wounds in the lower extremity, and quarter of the patients in the upper extremity. 60% in the dorsal region, and we had 1 patient in the head region. And outcomes, the wound size averaged around 20 centimeters square, and complete integration of dermal matrix in over 96% of the patients, and partial in 1%. The graft take, after the skin grafting look, 24 out of 25 patients had a complete graft take, with 1 person having partial graft loss. 4 patients had a bulge during the first look, which was punctured and the serous or sanguineous fluid was absorbed. A pie chart denoting the complete graft take, hematoma seroma formation, and the final at 3 months, the functional recovery was 80%, patient satisfaction is 96%, and there was minimal scarring when we compared with the Vancouver scar scale, where we used vascularity, pigmentation, pliability, and thickness. This is a proud graph showing 96% patient satisfaction and 80% of functional recovery and minimal scarring. Coming to the clinical photograph, a young boy hailing from Canada for his vacation in India, where he suffered a crush injury in the distal palm and proximal phalanx region. Minimal debridement was done, and then dermal matrix was applied. This was at 3 months. Slight muscular disuse atrophy is noted, but still his wound healed well. A 65-year-old lady, lateral malleolar ulcer, non-healing or chronic wound. Stage 1 dermal matrix, stage 2 grafting, and the color match and skin quality was good. An unknown bite, as well as an uncontrolled diabetes mellitus. Necrotizing fasciitis, serial debridement was done. Or the extensive digital and communis and extensor indices, the matrix was applied, and the wound healed really well, and the patient's extensor movement was intact. A 1-year-old baby girl fell off the train into the railway track, a severe degloving foot injury, bone depth, and a tailor-made dermal implant over the posterior region. Pictures after grafting and at 3 months. Dramatic total scalp avulsion, where the calvarial periosteum got exposed in the frontal and anterior parietal region. A bit of chiseling was done, and then dermal matrix was applied. The pliability of the skin was good, however, she had a little bit of hyperpigmentation. This was our first patient. His Achilles tendon got exposed. So, in conclusion, it enhances the wound bed vascularization and good success rate. However, the upfront cost was a bit on the higher factor. And the future holds the 3D printed, tailor-made for a patient's anatomy could be there. Stem cell integrated implants. So this is a shining example of how far plastic surgery has come, bridging the traditional approaches and modern tissue engineering methods. This was so satisfying when our first patient came walking to the OPD with proper all stances of foot walking gait. So we are walking towards a new future. So this is a good option to sustain its presence in the reconstructive lab. Thank you.
Thank you for finishing in time.
Thank you, sir.
Yeah. Same question to you also. How do you choose your patients?
So first, the depth is the main thing, sir. If there is a good loss of bulk, then flap would be the workhorse thing we would suggest upon. And in a compressed and aesthetically anatomical part like exposed hands, we would like to choose the dermal implants.
Irrespective of, in all the cases you put dermal implants?
Provided it's not till the intraosseous depth, sir. If periosteum is exposed or paratendon region, we are all good to use dermal implants.
Second degree burns, would you use dermal matrices?
Second degree burns, yes, sir.
You will use?
Yes, sir.
What is the benefit?
So the elastin component can improve the elastic texture and reduces the burn contracture.
In hands?
Yes, sir.
In other areas?
In torso, it shouldn't be a problem, sir.
It shouldn't be a problem. Using should not be or not?
We can use in torso region.
Then the perspective.
Yes, sir.
Any questions?
How did you assess the function?
Sir?
How did you assess the function, functional outcome?
Over the joint regions, if all the full range of motions was present or not. So that was the key indicator for our functional outcome.
That depends on the severity of the injury.
One presentation said you can have bridging phenomena of exposed bone for 2 centimeter across.
Okay.
You are saying that you will put only when there is a periosteum and vascular surface.
Yes.
How will you justify? How will you justify the contradiction?
Sir, excuse me, sir.
One presentation said you can bridge, you can have bridging phenomena for approximately 2 centimeter.
Okay, sir.
That means you can put the dermal matrix over exposed bone.
Yes, sir.
You said you have put all the dermal matrix only when there is a periosteum and vascular surface.
Yes, sir.
How do you contradict, means that contradiction, can you explain?
So our prime motive was to enhance the vascular outcome after that
So you,
dermal matrix.
all your patients had vascular bed.
No, so periosteum exposed, we did a bit of chiseling to enhance the vascular.
Periosteum is a vascular bed.
Yes.
No, he said chiseling is done, so periosteum is gone. Your cortex is removed. Just like your pericranium, the exposed cranium,
yes, sir.
External cortex you have removed.
Yes, sir.
So you have got, they are narrow.
Yes, sir.
Isn't it?
Yes, sir.
So that is the vascular area. Can you put skin graft directly over the marrow of the skull rather than putting a dermal matrix and then put a graft?
So the pliability improves with the dermal matrix. And the adherence property over the direct periosteum is very less for a split thickness skin graft. So we choose to put dermal implants.
Dermal matrix is not implants.
Dermal matrices.
Why not put a graft directly over periosteum? That will be even more pliable.
Yes, please.
In one of the slides you have shown exposed tendons covered with multiple strips of this matrix.
Yes.
So how do you immobilize those strips?
So initially we just put a splint and a volar aspect and we had put a vacuum on top of that, sir.
Okay, thank you.
Thank you very much, sir.
I think with this we finish the session of Dr. Aral Manchanda Best Paper Award.
Of the data. So please do not do that. Just like one of the slides says, this is recurrent scar or recurrent keloid, and this is refractory keloid. Everybody knows what is refractory keloid. So please don't show such images. So these are some of the points I thought extempore I can tell to younger group, because some of you are sitting here, which might be useful in your future competitions and presentations. Thank you.
Very important.
I request all the speakers to give their presentation to the audiovisual team in the preview area. Yeah, you start. Yeah.
A very good morning, everyone. Today, I am Dr. Prakhar Kesavani, currently third year resident, doing my MCCTC from Department of Plastic Surgery, AIIMS, Rishikesh. This was my thesis topic which I recently submitted. Exploring role of assessment of pedicle velocity using Doppler ultrasonography following microvascular anastomosis in a free flap surgery. We all know that a free flap is a cornerstone of reconstruction. It stands the highest position in a reconstructive ladder, while in cases of reconstructive elevator, we give it a priority in difficult cases. Success rate stands more than 95%, while overall thrombosis rate is 5 to 10%. Early catching of venous congestive cases and exploration can salvage the flap, and 50 to 85% flap can be salvaged. Strict post-operative monitoring is the key, and clinical monitoring is always the gold standard. We all know about the virtuous triad. It states about 3 factors which points towards the possible thrombosis. First is hypercoagulability, then endothelial injury, which is inevitable in a microvascular anastomosis, and then we have altered blood flow. For this, to study the hemodynamics of free flap, we conducted this study. Physics of flow can be summarized by 4 famous equations. Hagen-Poiseuille law, which states that flow is directly proportional to the 4th power of radius, while inversely proportional to the length of vessel. Ohm's law, which using same Hagen-Poiseuille formulas, gives the relation of resistance, which becomes inverse. Venturi effect, we all know that flow is equal to velocity into cross-sectional area. Therefore, whenever there is a stenosis, velocity will increase at that point. And then we have critical closing pressure, which states that whenever there is fall of blood pressure after a critical value, the blood vessel can collapse. We have used Doppler ultrasonography. For this, it is a real-time non-invasive tool to assess vascular flow. We require a proper understanding of Doppler equations, the most important point being the cos theta, that is the angle at which we are measuring. It should be less than 60 degrees. Then a waveform, normal arterial waveform is triphasic, while venous waveform is monophasic. Apart from that, there are certain indices like SD ratio, resistive index and pulsatility index. And then we have knobology, which is a depth, gain and all ultrasound settings. These are the list of previous studies which highlight the importance of vascular flow in free flap surgeries. The main prototype study, which there is only a single study which has measured the velocity changes after microvascular anastomosis, conducted by Hanesono in 2009. He concluded that immediately post anastomosis there is a significant increase in velocity, while velocity increases significantly even if after post-op day 7 and 28. The aim of this study was to understand the pattern of velocity changes in free DIP, free flap surgeries. Then secondary objective was to see the thrombotic relation with the velocity changes. The study was conducted as a prospective observational study, and all consecutive subjects regarding free flap surgery in Department of Plastic Surgery AIIMS case were included after taking informed consent. Patients with known angiopathies were excluded from the study. Statistical analysis was done using repeated measure ANOVA, and pairwise correction was done after Bonferré correction. P-value less than 0.05 was taken as significant. We used a 4 to 15 MHz high frequency sonography probe, and velocities were measured at 4 points. V0 before pedicle division, V1 20 minutes after successful anastomosis, V2 after post-op day 5 when patient started ambulating, and V3 after POD 28. It's not moving forward. This is the schematic flow chart of a study. We have measured V0 before, after free flap dissection and before pedicle division, V1 20 minutes after anastomosis, V2 and V3. The results we were able to include 35 patients, age range from 5 to 82 years, almost equal participation from male to female, 17 and 18. There were mainly 3 reasons of reconstruction: breast 14 patients, head and neck 12 participants, and extremity 9 patients. The velocity changes were seen that there was a significant effect of time observed in both arterial and venous velocity. Peak velocity was noted at V2 measurement, that is post-operative day 5 to 7. And there was a gradual normalization of by the time V3. So from V0 to V1 we found a slight decrease, but this decrease was insignificant. Then from V1 to V2 we found an increase in velocity. This was highly significant. Actually P was 0.0003. And then from V2 to V3 there was a slight decrease and it was insignificant. So these are the chart for the velocity trends. Red is arterial velocity and blue is venous velocity. Overall V1 and immediately after anastomosis there was not a significant change, while in long term after POD5 and POD28 there was a significant increase in vessel velocity. These were the outcomes in terms of flap survival. 31 out of 35 patients showed bright red bleed from the very starting. 2 patients showed intraoperative signs of congestion and it were resolved with intraoperative division of anastomosis. 2 out of 35 patients showed post-operative signs of venous congestion. 1 was due to mechanical compression and kinking of vessels, while second was due to venous thrombosis. When we analyzed this single patient, this was the outcome graphical representation of same thing. Since we had only single cohort, very small cohort of thrombotic patient, that was 1. A deviation was observed from normal pattern. We were observing that there was a slight decrease from V0 to V1 and it was insignificant. But in this patient, rather than decrease, there was an increase. As we discussed earlier, using the Venturi phenomena and all, there can be a possible hypothesis that there was some obstruction or narrowing of vessels which we could have caught at that time, which was leading to a sudden increase of velocity. Here we also suggest that at the same time we should have studied waveform also, because a sudden peak in velocity might be indicative of.
Please conclude.
Discussion is velocity increases.
Please wind up. We are running short of time, almost 1 hour started.
Thank you.
Any questions from audience to Dr. Parkar?
How do you are using a hand Doppler
yes,
to identify that?
Yes.
So how you identify that the signals which are coming is from your anastomotic vein or artery which you have used, not the other vein and artery, particularly in head and neck?
Sir, mostly the vessels used for anastomosis were a facial vessel, which is found at a particular landmark. If we find that the landmark of vessel will be difficult, we usually mark the surface with a non-absorbable suture till POD 28.
Any other questions to him?
How have you considered the blood pressure of the patient in every cases?
During
pre-op, intra-op and post-operative?
All these patients were operated electively, blood pressure was controlled. And
no, not blood pressure control. No. Exact. That different patients have different blood pressure. Pre-op, intra-op and post-op.
Yes.
The blood pressure varies. During intra-op, at the end of surgery, the BP comes down. Have you considered that? What is your implication of that?
We had this thing in mind that if BP drops down, the anastomosis can collapse. We ensured that the BP was constant in these patients. We tried to avoid any kind of severe fluctuation in BP. But yes, as a strict parameter, we haven't taken a groups of specific BP. But it is just a general trend of flow. We are just comparing the same parameter in same patient. We are not comparing two different patients. We are just seeing the velocity trends in the same patient. All other parameters being constant.
But physiologically, blood pressure correlates with flow, no? It should be considered
flow,
in every cases.
Absolutely, that's what we are measuring.
From your initial beginning slides. That
yes, sir. We are actually not measuring the absolute value of velocity. We are just seeing a trend of how velocity changes. That's the only. All other parameters have been kept constant during this measurement.
Okay. Thank you, Dr. Lothar.
Yes.
I request all the speakers to stick to the time.
The next speaker is Dr.
Good morning, everyone. Today I am speaking on the topic of outcome analysis of a virtual planning for DIP flap breast reconstruction. So, as we know, the DIP flap is the gold standard for free autologous tissue breast reconstruction, and the volume estimation of the flap is very subjective, leading to a rough estimate of volume of flap required. For an inexperienced surgeon, surgery planning can be difficult, which may lead to breast asymmetries. And our purpose of study was to validate 3D scanning as a tool for objective planning of flap harvest and assessment of reconstruction outcome. Our objectives were to assess the correlation between preoperative volume calculated by 3D scanning and CT for testing the validity of 3D scanning, to evaluate association between abdominal volume calculated in the CT and volume of breast in post-operative period evaluated by 3D scanning, to evaluate the accuracy of planning by comparing volume of the healthy breast to the reconstructed breast using a paired t-test, and to find association between patient satisfaction score at 6 months post-op and difference in volume of reconstructed breast. A prospective observational study was conducted for a period of 2 years, and all females undergoing breast reconstruction with DIAP flap after mastectomy were included in our study. A preoperative evaluation of breast volume was done using Arctic scanner for 3D scanning and volume rendering software on CT scans. The volume of the abdominal tissue for flap harvest was also calculated using the CT images by volume rendering software. The CT angiography images were saved in DICOM format, and breast volume was estimated in a coronal image manually using freehand volume rendering tool, and breast outline was marked in each slice. And the volume in each slice was recorded by the software, and a final image created from the selected region of interest gives the total volume of the breast. Similarly, the region of interest is marked in each slice of abdomen, and final volume of the abdomen required was also calculated by volume rendering software, and the perforators were also marked with respect to the umbilicus. The volume calculation by 3D scanning was done. The breast was scanned using Arctic 3D scanner with patient in standing position. Using Arctic Studio, the final contouring model of the breast was done to remove background noise caused by the movement of the patient. And the ROI was marked after defining the margins of the breast. And this ROI is then imported to piece properties section of the software, and the volume was calculated. We had 15 patients in our study who were evaluated between the age group of 26 to 48 years with the mean age of 38.6 years. 10 patients underwent unilateral DIAP reconstruction, and 5 patients underwent bilateral DIAP. In all cases, internal mammary artery was used as the recipient vessel, and the mean volume of the reconstructed breast was 682.5 cc, which was measured at 2 weeks post-operatively by 3D scanning. The mean breast Q scores regarding satisfaction with breast reconstruction was also evaluated at 6 months post-op, and it was found to be 74. This is a tabular column depicting the volumes and the data of the patient. On comparison of the volume of reconstructed breast with that of the healthy breast by t-test, we found no statistically significant difference between the two. And on evaluation of abdominal volume calculated by CT and breast volume by 3D scanner, we found a high correlation between the two techniques. And on comparing the breast volume obtained using 3D scanning with that of CT, the interclass correlation coefficient demonstrated excellent reliability. We correlated the volume differences between the normal and the reconstructed breast and with that of the breast Q score, and found a good association between the variables. And the study also revealed a strong negative correlation, which means a higher breast Q score was seen when there was less difference between the normal and the reconstructed breast. Here is a case of right-sided carcinoma breast managed by skin-sparing mastectomy reconstructed with the DIAP flap breast reconstruction. And this is other case where there was a left-sided CA breast managed by modified radical mastectomy and DIP flap breast reconstruction. This is a young female with malignant phylloids treated with mastectomy followed by breast reconstruction with DIP. So far, the volume estimations have been done by plaster casting, water displacement techniques, anthropometric measurements, MRIs and CTs. Displacement and casting techniques were quite uncomfortable for the patient. MRI, though, was found to be accurate, but is a little expensive and time consuming and also not a part of regular protocol. And CT scans in the post-operative period is not recommended due to higher radiation exposure. 3D scanning is found to be less invasive, quick to perform, and allows analysis of the patient in standing position, which maintains one's normal breast shape, unlike CT or MRI. And Lee et al. Found that there was a significant reliability and a linear association between 3D scanning and MRI, but there was a low agreement between the two techniques. Rene et al. In another study found that 3D imaging system measures lower volume for breast than MRI. However, 3D measurements shows a linear association with MRI and have an excellent reliability. In our study, we were able to demonstrate a high interclass correlation coefficient, which means a high reliability between CT volume and 3D scan volume. This technique is much better than the formula-based calculation of abdominal volume, which is also So we would like to conclude that patient satisfaction with the outcome also depends on minimal asymmetry between volume of normal and reconstructed breast, and volume measurement by 3D can be an effective tool in predicting the volume of tissue required and also maintaining the symmetry of the breast. Thank you.
Thank you. Any questions?
In view of the shortage of time, we can postpone the discussion to the lunch session. I request my co-chair, Dr. Manish, to invite the next speaker. I request all to stick to the time.
Next speaker is Dr. Shubhendu Khan. Will be discussing about bilateral